Good day and welcome to this public inquiry. Welcome to our viewing and listening audience to this, the 24th meeting of the Joint Select Committee of Social Services and Public Administration. Happy New Year to everyone. Thank you for being here and best wishes to everyone. This is the committee's fourth public hearing with stakeholders pursuant to its inquiry into Trinidad and Tobago's response to the prevalence of non-communicable diseases with specific focus on diabetes, cardiological diseases, and cancer, and related aspects of the public healthcare system. Members of the public are invited to submit their comments and questions via the Parliament's social media platforms, including YouTube, ParlView, or via Facebook and or Twitter. We thank you all for being with us today, including the Honourable Minister of Health, the Honourable Terence Singh, Minister of Health, and the Ministry of Health representatives. At this time, I'd like the members of the committee to introduce themselves, starting with Member Sinanan. Member Mohit.
Andana Mohit, member.
Roger Monroe, Vice Chairman.
Good morning. Esmond Ford, member.
Good morning, colleagues. Avinash Singh, member.
And I'm the committee's chairman, Paul Richards. I'd at this time like to invite the Honourable Terence Singh, Minister of Health, to introduce himself and his team.
Right. Good morning, all. Happy New Year to all. Thank you for the opportunity to be here. Terence Singh, Minister of Health, to my right, and I think they could introduce themselves.
Morning, Chair and members. Dr. Roshan Parasram, Chief Medical Officer.
Good morning, Chair and members. Dr. Maria Clapperton, Director of Non-communicable Diseases, Ministry of Health.
Good morning, Chair, members. Davlin Thomas, CEO, North Central Regional Health Authority.
Morning, Chair, members. Dr. Brian Amos, CEO, Southwest Regional Health Authority.
Thank you all for being here. We really appreciate you being here. It's an opportunity for us to interface, to get some information, and for the ministry to share its plans and policies moving forward for a healthier Trinidad and Tobago. Among the broad issues we are to consider today are some of the systemic issues and resources and their shortcomings in some instances among the RHAs, policies, plans, and legislative action of the government for mitigating the escalation and managing NCDs and challenges presently confronting the government in that regard. The government's performance in nudging the population toward healthier lifestyle choices, strategic partnerships and collaborations with the private sector and civil society in combating and managing the prevalence of NCDs, and the medium-term and long-term national goals of the government as it relates to reducing the levels of NCDs among Trinidad and Tobago. At this time, I'd like to invite the Honourable Terence Singh, Minister of Health, to make brief opening remarks. Minister.
Thank you very much. Good morning, Mr. Chairman, members of the Select Committee, and members of the viewing public. I take this opportunity, Chairman, to reaffirm the commitment of the Ministry of Health and the RHAs in the provision of health services and its supporting programs, and in particular, the prevention, treatment, and care and control of non-communicable diseases. It is recognized globally that NCDs disproportionately affect people in low and middle income countries. That could be encapsulated in the term, the social determinants of health, where nearly 3/4 of global NCD deaths occur. Upon assuming office in September 2015, it was recognized there was a need to focus the NCD strategy on the upstream prevention needs, and this government shifted the focus from tertiary and secondary healthcare to one of prevention at the primary healthcare level. And this includes the decentralization of mental health and the inclusion of mental health as an NCD. Trinidad and Tobago led the way in that determination. Greater emphasis was placed on utilizing a life course approach, inclusive of measures to encourage behavior change and promote personal health and wellness. This life course approach employs an integrated health services model to satisfy the healthcare needs of the population by journeying them through their entire life course. The approach encompasses a myriad of programs and services from birth to infancy to early childhood, to adolescence, to adulthood, and to the elderly, thereby securing a healthy, sustainable future for our population. Another key focus is empowering individuals, families, and communities to take charge of their own health through self-management and behavioral change. It is envisaged, Mr. Chair and members, that this integrated primary health care-oriented life course approach will consistently lead to improved health and, by extension, economic outcomes, enhance health equity, and improve efficiency overall. Additionally, during the period 2016 to 2024, there were several initiatives implemented by the ministry using this life course approach. One, the establishment of a non-communicable diseases unit at the Ministry of Health, a first. The establishment of a national NCD steering committee, a first. The implementation and use of graphic warning labels on the packaging of tobacco products. Pregnancy, infancy to childhood. The design and implementation of the gestational diabetes management program. That simply means gestational diabetes, women who are pregnant. To identify patients with diabetes in pregnancy through universal screening, another first. The standardization of criteria and protocols and the provision of personal glucose monitors to 3,218 patients with the overall goal of improving maternal and newborn health outcomes. The achievement of attaining baby-friendly hospital accreditation, international status at several health facilities, for example, Mount Hope, Sangre Grande, Point Fortin, Scarborough. Mr. Chairman, as a result of our initiation of breastfeeding at birth, because that is recognized as one of the success factors in preventing childhood obesity, breastfeeding rates have moved from, that is early establishment of breastfeeding, from less than 10% in 2015 to between 80 and 95% at all public maternity units to date. Early childhood to adolescence, the banning of sugar-sweetened beverages in schools, the promotion of healthy lifestyles at schools and community centers, with the supply of exercise equipment to 478 primary schools, 134 secondary schools, 12 special needs schools, and 13 community centers. The launch of TT Moves Junior to promote adoption of healthy lifestyle practices amongst our youth via the hosting of Healthy Me camps and the launch of the NCD Inspector Academies targeted to children between the ages of 12 to 17. Adulthood and elderly, the re-energizing of the TT Moves Behavior Change campaign, inclusive of the hosting of several TT Moves Health and Wellness festivals across all 5 RHAs. Signage engaging the public towards a healthier lifestyle with key messages encouraging persons to drink more water, eat more fruits and vegetables, and to move more. In addition, the procurement and operationalization of 6 mobile health units, the men's and women's wellness initiatives, which are mainly geared towards screening, diagnosis, and management of 4 major NCDs, including cancer. The activities included counseling and education for key services, not only limited to cancer, but also drug and alcohol use, mental health, sexual reproductive health, diabetes, hypertension, vision and hearing, and HIV/AIDS. The introduction and 100% scale-up of the Hearts Initiative. This is a program that focuses on reducing the burden of cardiovascular diseases through effective management of hypertension and high blood pressure across all health centers, with over 66,000 persons being enrolled and 28,237, or 43% of them, having achieved control of their hypertension to date, another first for Trinidad and Tobago. The standardization and restructuring of our diabetes wellness clinics and its establishment at all RHAs with supporting guidelines and protocols. the establishment of the Diabetic Foot Management Initiative with the resultant reduction of major lower limb amputations by 16% to date. We have never done that before. The operationalization of the National Lung Cancer Early Detection and Management Clinic at Eric Williams Medical Sciences Complex. The completion of the second National NCD Risk Factor Survey to collect up-to-date information on and assess the current burden of NCDs and NCD risk factor behavior within the population. The first National NCD Primary Care Training Initiative for all RHAs, which was a series of 5 workshops per RHA for physicians and nurses in primary healthcare capacity building initiatives. The launch of the NCD hotline, 800 NCD, on August 6, 2024, to strengthen linkage to care and promote self-management amongst persons living with NCDs. This service is available toll-free and is accessible 24/7 and is supported by a number of physicians. Through these physicians, the pilot project provides medical advice to callers who may be seeking to address queries that they may have regarding their blood sugar readings, HbA1c readings, and cholesterol blood test results. This service in particular, Mr. Chairman and members, supports and enables persons towards self-management of their conditions. Coming to the end, the launch of the Know Your Numbers campaign and the production of a supporting Know Your Numbers booklet, which not only provides health information, but also provides a mechanism for persons to document, monitor, and track their blood sugar and blood sugar readings all in one place. The establishment of Clinical Guidelines Review Subcommittee for the standardization of clinical practice guidelines for major NCDs. Mr. Chairman, the above-mentioned activities, the ministry's strategies for addressing the issue of non-communicable diseases, is an integrated, and this is important, primary healthcare-based approach as opposed to hospitalization. Enhance equity and improve efficiency at a fraction of the cost previously. Mr. Chairman, as I close, and members of the committee, we will thank you for questions which you will pose, and we are here to inform and educate the public. Thank you very much.
Thank you very much, Minister Dayasingh. Your introduction was so comprehensive. You've wiped out my first 3 questions. But we have 17 more. So thank you for that. Minister, you're on record as saying that NCDs, of course, as we know globally, pose the biggest threat to health in countries across the world and devastate populations for many different reasons. And that we can't, and I'm paraphrasing here, we cannot fund our way out of a health crisis. I think the CMO also indicated that upon one of our interfaces. And it's not about pouring more money into the system. It's about changing the lifestyle choices and patterns in the society. I know you would have covered some of the ministry's policies and strategies in your introduction. But can you indicate to us, as the Minister of Health, if you think we are close to turning the corner in resonating the issues with the population at large for personal responsibility and family responsibility, or is it seeming to be a challenge in changing those lifestyle choices and patterns?
Thank you for the question, Chair. So this NCD epidemic is 100 years in the making. The early literature points to the 1920s and 1930s, where physicians in the United States were dropping dead. And that's when the whole issue of cholesterol and plaque came into focus. It is exacerbated by our movement away from an agricultural setting where you are active to urbanization, a movement away from physical labor to desk labor. Look at what we are doing, sitting. It coincides with the Americanization of our diets. It coincides with the adoption of technology where children no longer play but sit in front of a screen. So yes, it is a global challenge. What have we done? And this is where Dr. Clapperton will come in. I always say you can't manage what you can't measure. We recently redid our STEP survey, which was first done in 2011, and we have some results of the 2024 survey, which will tell us, and Dr. Clapperton could go into more detail, what is the current status of health of the country and what the challenges are in terms of how we eat, alcohol consumption, tobacco consumption, movement, and so on. There have been some gains, but one of the major success factors is going to be for the population, and I mentioned this, to undertake self-management and recognize that they also have a role to play.
Thank you. Can Dr. Clapperton give us, thank you, with that cue from the Minister, a sense of where we are? I know we would have covered some of it in our town hall meetings in terms of levels of cardiovascular disease, levels of, if I'm not mistaken, there's three main types of cancer, prostate, breast, and lung cancer, or any other type that is prevalent in society, where we are and how the data is, the direction the data is pointing to in terms of our mitigation or management of those, please.
Good morning again, Chair, through you. So in 2024, the Ministry of Health has recently completed the second iteration of the PAHO WHO STEP survey. And the STEP survey is basically a survey that measures the levels of risk factors for non-communicable diseases within a population. And by repeating the STEP survey, we are also able to make comparisons between the recently completed survey and ones that may have been completed before. As for Trinidad and Tobago, there was one done in 2011. So looking at key NCD risk factors, especially the ones that relate to behaviors inherent within the population, we are able to have an idea as to the current levels of risk factors within the population and even have an idea to project in terms of the future burden of non-communicable diseases. So I will just take you through some of the key findings from the recently completed 2024 survey. With respect to, so this survey was conducted in persons, adults in the non-institutionalized population in Trinidad and Tobago from ages 18 to 69. The prevalence of tobacco use, that is the percentage of persons who currently smoke tobacco, we found that to be 21.3%. There was a higher prevalence among males as opposed to females. The prevalence of alcohol consumption, that is the percentage of those who currently drink alcohol or consumed alcohol within the past 30 days of administering the survey. We found a prevalence of 51.5%, 59.6% in males, and 43.4% females. What we noted here was that in 2011, the prevalence of alcohol consumption was 40.6%, so there was a 10.9% increase between 2011 and 2024. And with respect to consumption patterns, it was observed that even though males consumed more alcohols than females, we noted a significant increase in the consumption of alcohol among females, and this was found to be an increase of 12.5%. With respect to dietary practices, we looked at the percentage of persons who consumed the required 5 servings of fruits and vegetables per day. We found that 93.3% of the population consumed less than 5 servings of fruits and vegetables per day. With respect to levels of physical activity, and this was defined by the World Health Organization for the purpose of this survey, we utilized the definition a minimum of 150 minutes of moderate intensity activity per week. And this was further explained to participants with the use of pictures, etc. And we found that the median time spent on physical activity per day was 102.9 minutes, which had increased in comparison to the previous survey conducted in 2011. For the first time in Trinidad and Tobago, And this, as previously mentioned by the Honorable Minister, the Minister of Health took a position in 2018 to include mental health as a non-communicable disease. And in this same vein, the 2024 iteration of the STEPS survey included a newly introduced module from PAHO WHO, which assesses the levels of symptoms for depression among members of the population within the past 12 months. So we included a mental health module. So with respect to the persons who responded in terms of symptoms for depression within the past 12 months of administering the survey, we found a prevalence of 13.6%, with the larger proportion being among females as opposed to males. So to further assess the burden of NCDs within the population, we looked at a combination of 5 risk factors. So we went through some of these risk factor behaviors previously. So while I go through the 5 risk factors that we look at, I encourage the listening public to assess yourselves and see how many of these 5 risk factors that you may already exhibit, because this gives us an indication of the future burden of non-communicable diseases. And these 5 risk factors that we looked at in terms of combined risk are as follows: current daily smokers, persons who consumed less than 5 servings of fruits and vegetables per day, low levels of physical activity, being overweight, that is having a BMI of greater than or equal to 25, and having raised blood pressure, that is having blood pressure readings greater than or equal to 140/90. And we found that 1.6% of the population had 0 of these risk factors, whereas 38.4% of the population had 3 or more of these 5 risk factors. With respect to raised blood pressure, there was a prevalence of 29.0% of persons with having a raised blood pressure. Fasting blood glucose levels, there was a prevalence of 15.8% of persons having a raised blood glucose level, and 39.6% had the prevalence of elevated or raised cholesterol was 39.6%. Additionally, again, to look at the future risk or to project the future burden of cardiovascular disease within the population, and based on the data that we already collected, we were able to do calculations to assess the 10-year cardiovascular disease risk among persons who we surveyed, and to do calculations, weighted calculations, to make this applicable to the population. So this risk could either be 10%, 10 to 20%, or greater than or equal to 20%. And we found that persons within the age group 40 to 69 who had a 10-year cardiovascular disease risk of greater than or equal to 20%, that prevalence was 11.8%. So that is the risk of having a cardiac or cardiovascular acute event within the next 10 years.
Can I ask you, Dr. Clapton, to put a pause there? There's a lot to digest.
Yes, that's
We'll
the
probably
end of
get
it,
back to some
actually.
stats on who. If we can, if you could supply the STEP survey to the committee, if it's not prohibited, we would appreciate that. I think the minister's acquiescing.
So there's a final review to take place together with PAHO. Once that is done, it will become a public document, and we will certainly share it.
Thank you so much. Just before I go to Member Sinanan, just 2 quick questions. The sample size for that survey was?
Apologies. The calculated sample size was 5,404, and the actual response that we received was a total of 4,052 respondents.
Thank you. Minister, if I could defer to the CMO. One of the startling data points Dr. Clapperton identified to me among the risk factors was that alcohol usage in the sample went up by almost 10% in 13 years. That, to me, is striking. More than that, 59.6% of men in the sample consumed alcohol in the last 30 days. Dr. Parasam, what impact does that have on the population's health overall, or those who are caught in that demographic, in terms of predisposing them to NCDs and, by extension, the strain it puts on the national healthcare grid?
So looking at that figure in itself, in isolation, we can't utilize that data alone, because we're looking at someone that would have consumed alcohol within the last 30 days, right? We're not quantifying it in terms of the number of beverages you consume per day and that sort of thing. So that is done. In terms of Dr. Clapperton has more granular details as to that particular figure. And maybe she could provide that first. But in terms of so having noted that, generally the trend is a small increase in even the consumption in terms of per day. Alcohol being one of the risk factors, as you know, that is linked to a number of NCDs. For example, it has been associated now clearly in the literature for the development of certain types of cancers, for example, and alcohol by itself is a risk factor for certain mental health diseases as well. So being an increase in any of the risk factors, and as she showed, the combined effect of increasing not one but multiple risk factors, of course, redounds to having a population more at risk of events, acute events occurring in the near future. So our multi-pronged approach was really to decrease all the risk factors, at least not simultaneously, but at least in our public education systematically. Try to have targeted interventions to decrease all of them over a period of time, thereby redounding to the decreased risk in the population, at the population level. Noting that if we, at the ministry, take a whole of government, whole of society approach, it always comes down to, regardless of how our public education is done, to the individual and making those individual level decisions. And that's why we need the cooperation of all to get these things inculcated as part of our culture. And that's the difficult part about having an NCD program and a prevention program, because you could speak about it, you can educate about it, but at the end of the day, when you go home to your houses and you make those decisions one-on-one with yourself as to what to eat and what to drink, have we done enough in terms of being able to have the behavior change aspect of it identified so that people make those right choices?
Even before the final report is done, has the ministry been able to do a comparative with our regional counterparts in terms of how our data points are lining up with regional counterparts?
So we have international, and Maria could go into details. She just didn't want to go into the full report, but she could go into details as to the international benchmarks, as well, of course, if we're looking at individual, she could probably tell us which ones are above normal and below normal in terms of Trinidad, as expected by the WHO international guidelines. So I don't know if you want us to go a little more granular at this point, and then we can have
not right now, but we have a lot of questions, but we will get to that.
But we could,
Minister Sinanan, and then I think Member Monroe, has a follow-up in terms of alcohol consumption, and then Member Sinanan. So in terms of the link between alcohol consumption.
Thank you, Chairman. Given the findings that are linked between alcohol consumption and non-communicable diseases, is the ministry considering restrictions on advertising sale of alcohol beverages?
So that will have to be a policy position. Restricting the advertising of alcohol is not something that the Ministry of Health is considering right now as a policy position. What we have always advised people to do is to make the wise choices. And it's not only about alcohol. I don't want us to focus on alcohol. It's about a lifestyle change, inclusive of alcohol, tobacco, eating better, and moving more. So it's not about banning anything. It's about nudging. I think the chairman has used the word nudging the population to achieve a healthier lifestyle and to make choices in what you consume and how you move.
Member Sinanan?
Sorry, the minister did indicate in his opening remarks he answered a significant amount of questions that we would have posed. But just for clarity, in your 2023 annual report, it was stated that Trinidad and Tobago approach to the implementation of the 2030 Global Development Agenda. It will begin with the core areas, including the maternal mortality containment, HIV/AIDS, and the reduction in the incident of NCDs. You did indicate significant progress. But in terms of are you satisfied with the level of progress that you would have made in those areas over the last 2 years?
So on the questions, thanks for the question, member, and through you, Chair. On the incidence of maternal mortality, we achieved our SDG goals, which we were supposed to achieve in 2030. We actually achieved those in 2018. The number of women dying in childbirth has decreased significantly, and Trinidad and Tobago is recognized as a global leader in how to do that. So yes, I am happy with that. You asked about the issue of HIV/AIDS. The UN adopted a standard back in 2015, without going into the complex details, to achieve a cascade of what we call 90-90-90 by 2020. That has since been adjusted to 95-95-95 by 2030. What does that mean? It means that to eradicate HIV as a global issue, a country must know the number of people living with HIV. 95% of those people living with HIV must know their status. So that's the first 95. We are at 93, so we are just 2 percentage points off of that. We have made significant progress with that. Of that amount of people who know their status, so let's take this room. We have 20 of us here. If 20 of us know our status, then 95% of those must be on what we call ART, antiretroviral therapy. That is drugs. We are currently at 75%. So the second cascade is 75. The first one is 93. And then of those people on antiretroviral therapy, 95% of those must have a level of the virus in your system where it is not easily communicated to another person. You must be what we call virally suppressed. We are currently at 96%. So the UN has set 95, 95, 95 by 2030. Our current status is 93, 75, 96. So we have made some significant progress. So that's the answer on those two parameters.
Thank you. Are there any challenges in the availability of antiretroviral
Absolutely
therapy drugs?
none.
None.
Absolutely
Member
none.
Mohit? Thank you.
Thank you very much, Mr. Chairman. Good morning again, Minister. In your opening address, which was pretty lengthy, giving us quite a lot of information, I get the point of self-management. I get the point that the ministry is also educating the public on self-management. But the issue of vaping, in terms of policy and legislation, does the ministry have any plans as it relates to the Tobacco Act in terms of amending it to deal with the issue of vaping? And how does vaping contribute to cancer? Any statistics or anything like that in Trinidad and Tobago? If you can give us some information on that.
So I will tell you what I told the Senate I will tell you what I told the Senate in response to this exact same question. The issue of vaping is primarily amongst our teenage population. So with the Executive Secretariat of the Inter-American Drug Abuse Control Commission, the Organization of American States, we conducted a regional training of trainers in the Universal Prevention Curriculum Practitioner Series Prevention in the Caribbean region. The UPC school-based prevention course, we are rolling that out to all the schools. What we have done so far is in 2023, a preventative approach to vaping amongst children and other key populations was adopted. We conducted 12 health education centers at various schools across the country and sensitized approximately 12 to 1,500 students about the health risks and dangers and alternatives to e-cigarettes and vaping. Basically, what we are doing at this stage is collecting the baseline data. We are doing the interventions and actions, and that will be the precursor to any legislative change which is being suggested to the Tobacco Act. As the effects of vaping on children, I will defer to the CMO.
You asked the particular question in terms of relation to cancer. So in terms of vaping, the medical side effects is emerging because it's a relatively new phenomenon in terms, it's not like tobacco that has been around for quite a long time. So in terms of effects, you're seeing the acute effects generally in terms of the respiratory system and the cardiovascular system are the main concerns at this point. In terms of longer term effects for longer lasting use, there hasn't been any, as far as I'm aware, any research linking with that linkage to cancer, which of course in the past has been strong as it relates to tobacco use. So there is a link to tobacco. So yeah, more or less that is the health effects, but it is a new phenomenon. Research is ongoing and it is being, well, basically the health effects are being elaborated as we go and as more and more research comes to us.
Just before Member Mohit continues, just for clarity, so there's no active consideration being given by the government now in terms of amending the Tobacco Control Act to deal with vaping, even while you are collecting the baseline data, because my understanding and my research on the issue is that the countries that have outlawed vaping is because of the propensity of the amount of information that speaks to, one, the adverse health effects, the epithelial cells in the throat are being damaged and making younger people in particular more susceptible to respiratory issues. And two, it serves as a jump-off point from vaping to tobacco use. And countries have been proactive in understanding that scientifically, empirically, and making moves to amend their laws to deal with that.
Yeah. So the position of the Ministry of Health at this point in time is to look at the issue of vaping in Trinidad actively, do the preventative work at the level of the schools, and as I said, this will form the precursor to inform legislative changes moving forward. So legislative change is something we are looking at, but we don't have a policy position now to say, yes, we are banning vaping. It is something that will come in the future as we look at it.
Well, I hope so, but I just put on the record that it's very disturbing for me to drive down Frederick Street and see children in school uniform with vaping pipes regularly. And it's becoming more and more prevalent, even walking around the streets. Member Mohit?
So, Minister, based on your response, do you think, as of today, your ministry will take a more aggressive approach in at least trying to provide a policy as soon as possible as it relates to vaping?
Yes.
Additionally, Minister, as we look at legislation again, are there any plans as it relates to front of package labels, taxation on unhealthy foods, restriction on advertising, etc.? Because I think some years ago, you would have met with fast food chains, yes, fast food chains, and you actually condemned them on the way they were advertising at the World Health Assembly. and nothing has really changed. Not much has have changed. So are there any type of legislative plan as it relates to unhealthy foods?
Yes, so I think I also made the point that people have to make wise choices. When you start to ban things wholesale across the board, it may lead to the reverse effect. If you remember back in the 1920s when the United States banned alcohol, it didn't decrease the consumption of alcohol, it just drove it underground. We live in an open market society, so we always advise the population, a lot of the onus is on you, and especially parents, not to overindulge in fast foods. It is not about banning anything. We have always advised the population and myself, and these are my words, do everything in moderation. On the issue of front-of-label packaging, that is a trade matter which the Honorable Paula Gopi School is leading at the CARICOM level. So the Ministry of Health works with the Ministry of Trade on that.
So, Minister, I get the issue of the population, but in terms of the fast food chains, you know, they were supposed to, based on your conversations, they were supposed to put healthier options on their menus. What has become of that?
So the last conversation I had with them last year, Maria, can remember the date, it had been around October. They had pledged to introduce it, and I think they have.
You think they have, or you
Yes.
can confirm?
It's voluntary.
Okay.
It's voluntary. I can't compel them. But we have to ask parents again to guide their children in making wise food decisions.
But, Minister, we are not speaking ban, but legislation can somehow regulate. So that's why I'm asking about legislation, not specifically banning anything.
What legislative measures would you recommend?
It will depend on your findings.
Yeah.
So that's why we're asking the question from the committee's end. If you have any planned legislation, just like vaping, in terms of packaging and unhealthy foods.
No, at this point in time, and I made that point clear when I spoke at the assembly, we have no plans to legislate what people eat. We ask people to make the wise decisions, and Dr. Clapperton could tell you we have done a lot of work in how to read labels, what is the salt content in French fries, 16 teaspoons of sugar in one soft drink, when your average daily intake should be, what, 6? Or thereabouts. But we have also worked with the soft drink manufacturers, and some of them, to their credit, have voluntarily reduced the amount of sugar in their drinks because of our intervention with them. And if you read their labels, you will see how much percent less sugar in some soft drinks and juices.
Just before we go to Member Monroe, following the question from Member Mohit, Minister and team, I understand your position of not wanting to ban, but other jurisdictions have found success because moral suasion doesn't always work, and sometimes it's availability, and a lot of it is marketing, and a lot of it means that while we try moral suasion, the NCD epidemic continues, putting a burden not only on the healthcare system, but on the human resource capacity of the population. And I guess that's why Member Mohit's advocacy comes into maybe try both at the same time. Moral suasion will work and personal choices should work, but also sometimes you have to legislate not for the consumption part, but from the supply part.
So it is not the ministry's position at this time to recommend that sort of harsh measure.
Thank you. Member Monroe.
Thank you very much, Chairman. Minister, I just want to follow up on the conversation of vaping and those stuff surrounding cancer. How has the ministry been able to respond to the increased cases of cancers thus far?
So let us deal with the issue of cancer, as you said. Let Dr. Clapperton start with what are the main cancers, and then I will go into what the ministry has done. So I think that's a good jump-off point. So again, coming out of the STEP survey and our cancer registry, Dr. Clapperton can start.
So again, recently, the Ministry of Health conducted an updated review of the data contained within the Elizabeth Hormonal Cancer Registry. And this report of 2024 captures data in Trinidad and Tobago on cancers from 2003 to 2020. And the information outlined is as follows. For the period 2003 to 2020, 43,380 individuals were diagnosed with cancer. 97.9% of those persons were over the age of 25. 49% of those diagnosed were male and 51% were female. 39% of persons were between the ages of 60 to 74 years old. 36.2% were Afro-Trinidadians and 23.0% were Indo-Trinidadian. In terms of the top 3 leading causes of cancer in men would be prostate cancer, followed by colorectal cancer, and then cancer of the lung and bronchus. Top 3 leading causes of cancer in women, breast cancer, followed by cancer of the uterus, and then colorectal cancer.
Right, so that is the landscape of the cancer burden in Trinidad and Tobago, broken up by numbers, demographic between the Afro population, the Indo population. What are we doing now at the ministry to manage this burden of cancer? The first thing we do is engage in education. We have done significant work in education. Then we do screening so that people will know what their status is. Members may have seen the recent prostate screening tests that we did for men, which does not mean a digital rectal exam. It's just a blood sample. After we screen, for those who need to be linked to care, we link them to care or treatment, and then palliation. So it's a whole approach from screening, education, treatment, and care. But over the past 10 years, we have made the following interventions. We have increased our imaging capacity so that the diagnosis becomes better, it becomes faster. Advances in radiotherapeutics, radiation. The extension of our infrastructural footprint, both at St. James and recently opened the Cancer Center of Trinidad and Tobago, the South Branch, which Dr. Moore will speak about when I'm finished. We made significant strides in our surgical procedures using laparoscopic surgeries more and more, which are minimally invasive, less blood loss, less recovery time. The switch to the digital platforms, expansion in blood testing, and key to make sure that we have the people going forward. 8 scholarships which were offered last year for the DM in oncology, the Doctor of Medicine in Oncology, 8 scholarships, and those 8 people have started their training this month. And then increased clinical trial research collaboration with agencies overseas. So that is what we have done. We have also introduced more brachytherapy, more LINAC training. We are going to have a MRI and CT installed in South in 2025. We had the first MRI installed in St. James last year. So all of these are the efforts for screening, linkage to care, and then palliation. I would like Dr. Moore to say now what he's doing with his Enhanced Cancer Center in South, which was formerly the Augustus Long Hospital.
Through you, Chair and members, the Cancer Center Trinidad and Tobago South was launched officially on the 14th of December last year. and that is a culmination of a strategy led by the government where there was agreement between Heritage Petroleum and the Ministry of Health in order to lease the Augustus Long Hospital long-term lease to the Southwest Regional Health Authority for the purposes of repurposing that building to house cancer services, which forms part of the national grid for cancer care now at this point in time. We consider the launch successful at this time. We have moved the services that were formerly at San Fernando General Hospital, and based on the burden of disease, naturally, it has outgrown the old facility, so therefore right now we are at the cancer center and we have moved most of the services. There's the outpatient clinic setting. We are going to finally move across by the end of the month the infrastructure and equipment such that we could move the chemotherapy services. And we also have, at the direction of the ministry with the spectrum of care, have a palliative care unit, a 15-bed palliative care unit, and for which, together with the support of the ministry and the population and the staff, the future diagnostics and so forth will be coming up in the next 2 years. So therefore, with the ambience of Augustus Long in of itself, plus the staff and services, we will be the south parallel to what is already occurring in the legacy northern facility at St. James.
Before we move on, Mr. Chair, you had mentioned, and Dr. Clapperton had mentioned lung cancer. Our lung cancer treatment facility is centralized and located in North Central, and I think Mr. Davlin Thomas could give the population, through you, Mr. Chair, some good information about that.
Through you, Chair. Thank you, Minister. The North Central Regional Health Authority currently manages a thoracic surgical department that does 2 tiers of services. One is that we engage directly in some of the outreach that is required. So we art exhibitions, etc., including school children. So we do that kind of outreach that the minister would have and the director for NCDs would have mentioned. But more directly, the thoracic surgical department is engaged in lung surgery and diagnosis, lung cancer surgery and diagnosis. We've just received what we call a body plethysmograph, which is one of the high-end pieces of equipment throughout the world. So we've recently commissioned our first plethysmograph. What that does is that absolutely and exponentially increases our ability to adequately diagnose. And we do have another one coming in. Well, it's in the country, and it should be commissioned before the end of this month. So in terms of diagnosis and treatment, and certainly surgery, that department is dedicated to that.
Member Ford and then Member Singh.
Thank you, Mr. Chairman. Again, throughout the inquiry, it was found that there is a gap between men seeking preventative care and screening. In light of the male-centered initiatives put forward by the ministry, 1, what are the targets set out for male involvement, and have these targets been met? 2, is the ministry satisfied with the current response to the male-focused initiatives and programs that have been launched by the ministries or the RHAs? Thirdly, are there any plans to expand programs targeting men? And again, fourthly, how was the ministry RHA able to get men to come out in their vast numbers to the various screening sessions that you all would have hosted throughout? As you know, Mr. Minister, I attended the one at Mount Hope.
Yes.
And I know it was a tremendous success because, you know, we men tend to not want to come out, you know, in order to check our health. So just give us a little briefing along those lines, please.
So through you, Mr. Chair, thank you, Member Ford, for the question. So if you take men and women, more women actively seek out health care. Less men do that. That is traditional around the world. Men feel we are invincible, you know, we're macho, we don't get sick. Good, right. Having said that, one of the major issues facing men, as Dr. Clapperton said, is the issue of prostate cancer and lung cancer because more men smoke. So what we have done, Mr. Davin Thomas just said what we are doing for lung cancer at Eric Williams. For the prostate screening, last year was the first time in Trinidad and Tobago we launched the finger prick blood sample for PSA testing. Before, for a man to know his status, he had to do the digital rectal exam or a PSA test where you take a blood sample, it has to go to a lab, you wait 14 days to get the result. With this screening, you get your results within 5 minutes. We had set a target of about 20,000 men should know their status within 1 year. The first screening, I think we got roughly about 5,000 men. Right now, with the influencer drive I have at the MassVac sites, included in that is also the prostate screening test. So men can go into any of these sites and get that done. So those were the targets we set. Am I happy with the way men are now responding? The answer is yes. Because it shows once you make it available and easy, the men will come out. Are we going to expand it? Yes. And I think Mr. Davlin Thomas could come in now because he pioneered the men's initiative at Mount Hope.
So to date, it's really what we would have done on the advice of the minister was to engage in creating a kind of habitable environment that would facilitate the encouragement of males to attend. So we engage in entertainment, etc. To date, the success rate is that we've, in the 4 or 5 that we've had so far, 5,000 men. And that is at a rate of about 1,000 men showing up in one day to have their testing done. That is significant. What we've also done as well is to streamline the care for those anomalies. So we've streamlined the test results to ensure that once we see these 5,000 persons, if we have some anomalies, we identify those persons and have separate clinics for those persons so that we could quickly bring them back to normalcy.
So let me just expand a little bit on that because the targets are important, Member Ford. When we did the first round of the new novel PSA testing, we got about between 7 or 10% of those men who had elevated PSAs. Now, traditionally, they would never know. And then when you catch them, it's stage 2, stage 3, stage 4. So we catch them early, and then we link them to care. And that's what I said. Part of the strategy for cancer is screening, early detection, and link to care. And what Mr. Thomas had done at NCRHA, as a direct answer to Member Ford, we made the environment such that men will want to come. They don't just come for a medical examination. They have barbering, pedicure, manicure, facial. So it's an environment which is non-threatening, which is relaxing, and then they get the medical advice and the screening done in that type of environment.
Follow up on that, and may I add my commendations because I saw some of those caravans and they were highly successful. Member Singh.
Yeah, I just.
And then member. I'm still not sorry, and then Member Singh.
Okay. Yeah. See. Okay. I mean, I appreciate the answer there, and I think that is a big plus. How to encourage people to come and do testing and so. I just want a confirmation. When we do these tests, you have to have a follow-up. And from time to time, you have to monitor any progress or anything. In terms of how your record keeping is with that. Because when you go to these clinics and so, even you go to RHA or anywhere, you have to create a file. In terms of using technology, if I go to this RHA today, tomorrow I move my residency and I am now in a different area. can I visit that area and my file is accessible, and what mechanisms you have in place to ensure that my file is not lost or misplaced, and you can actually check with technology now. The last time you did this test, it was at this level. This is what is showing up now, and I have that assurance that my file, one, is not misplaced, and I can access it at different agencies in the country.
Minister Sinanan lives at the Ministry of Health because the question he asked is a valid one. Patients over the years have been inconvenienced and bedeviled by the issue of lost files. That situation is untenable. As the health system evolves and changes, we have to adopt technology. And it is disheartening for a patient when you wait for a clinic appointment and you go, you can't find the files. That bothered me. So in 2023, we started to lay the groundwork for the adoption of technology. And Minister Sinanan wanted to know, if I move to an area, what happens? How can we judge the progression of your disease? So the adoption of technology through our healthcare system is a wide and deep and complicated process. So at the ministry, we took the decision to start to adopt technology in 4 key areas. 4 key areas that brings a level of commitment from our doctors and nurses which redounds to the benefit of the patient. What am I talking about? Minister Sinanan said if he moves. So if you are living in Diego Martin and your CT result is there and you go to San Fernando, you don't want that patient to do another CT. That is extra radiation, use of resources. There's something called a PACS system, basically PACS, Picture Archiving Communication System. On a PACS system, all images and reports are stored. For the first time in Trinidad and Tobago, RHAs can see and share your images across a PACS system. We are getting there. Different RHAs are a different thing, but at the end of this month, all images, a doctor in San Fernando can see the image you took in Sangre Grande. So you can see the progress of your disease when you see changes in the CT, changes in the MRI. That is underway. The CEOs will talk about that. 2, you draw blood. So you have a complete blood count, you have all your electrolytes. The lab information system, like the PAC system, is now being integrated. So I could see your blood results wherever you are in Trinidad and Tobago from 3 months ago. We are now using e-prescriptions. And finally, on the issue of lost files, we have started the process of digitizing our files. What we are doing is something called scan on demand, and I would like Dr. Armour to talk, because he's the pioneer of this in Southwest. So we have millions of files, but we can't digitize all at one time. So we are digitizing, in the first instance, the most active files. That is the patients who come to us most frequently. So just before I go to Dr. Armour, just to give Minister Sinanan the assurance that technology is being used right now. So a doctor can see my scan that I did in Arima if I go to San Fernando. That's the PAC system. He can see my blood work and the e-prescriptions. He can see what drug I was prescribed in Sangre Grande if I go to San Fernando. So that Dr.
Just
Armour,
before, Minister, just before you go to Dr. Armour, I will tell you that in our town hall meetings, this issue of filing and lost file and record keeping came up over and over again, and we were assured that the digitization and access issues, the ICT issues, were in an advanced state. Can you give us a sense of how advanced that process of digitization and digital access to patients' files has progressed?
So as I indicated, there will be millions of files. So we have prioritized and Dr. Moore could tell you, we have prioritized our recent patients. We are not going to digitize a file from a patient who died 20 years ago. We want to get the patient experience down pat. So we are digitizing files because, as I said, and I admitted it, lost files is an inexcusable thing to happen. And the issue of digitizing is one that we are actively engaged with, and I think Dr. Moore could come in at this point in time.
Through your chair, thank you, Minister. Yes, from a digitization perspective and the use of the staff, there is a lot of interconnectivity. Just permit me to give just a snapshot chronicle of what a patient experience is like in the digital system to explain or for the public to judge the level of advancement. So at any of our 5 emergency departments at present, if you go in for any treatment modality, the entire system is paperless. So from the time you enter, all members of staff, not only nurses and doctors, all the auxiliary staff, they all have access to computers and equipment, and they are able to speak to you, and they're able to create an electronic record for you. As the minister said, if it is thereafter require blood tests, it is taken, and rather than wait for the paper-based result to come, it's more instantaneous. As soon as the results are ready, the doctors and nurses can look on the computer and determine the results, and as the minister said, we could also determine now the past history of results that you took. The same occurs if you require any radiological imaging tests. And this also means on the back end, while the patient's experience is on the front end, I go for a CT scan or X-ray, and that the results are almost immediately available to the doctor. It's available in 2 ways. There are back-end doctors who do the report and put it on the electronic system, and also the doctors and nurses could look at the raw film and also make an instant analysis. And as the minister said, particularly with radiological imaging, because sometimes patients and caregivers, particularly if they come in very ill, they might not know the complete history. Doctors and nurses could not only pull up the test that they order for you, they could determine now if there's need to order a test because you have a previous result that's in the system if you did it in another RHA. So that is the sort of emergency department experience that there is overall. And also too, if you are seen in the emergency department and you are not a candidate for admission, as the minister said, there's also electronic prescription that's generated. You don't have to wait for a script. You simply leave where you are in the ED, you go straight to the pharmacy. Pharmacist has your prescription already and they dispense the medication for you. So that is the customer care experience that we have at the 5 emergency departments, and we at Southwest represent the Ministry of Health direction that is also emerging in varying degrees to the other RHAs.
Is that also available at Mr. Davlin's North Central Regional Authority?
Oh yes, currently, and in particular for the ancillary and auxiliary services. So, for example, the lab tests, the X-rays, CTs, and so on, MRI. We basically can see and report on X-rays, CTs, etc. at Southwest, Northwest, currently, Eastern, and basically throughout the North Central.
It's interconnected.
It's interconnected as we speak. And just to underscore the importance of it, that whilst the physical file that we're now scanning to digitalize is important, when the patient actually shows up at the doctor, the doctor needs to see whether the patient recently had any X-rays, CTs, etc. And that he gets to see that, he or she gets to see that in real time from any RHA that person would have been at, including the lab test, and more importantly as well now for us, pharmaceuticals.
What's the process of patients to access these files? One, because patients have said to us in the town hall meetings that some people told them, well, you can't get that file now. I guess part of the digitization would fix that. And also, coupled with that, technology and ICT is a double-edged sword. One of the issues patients articulated to us was that they get a diagnosis now and everybody knows their business in half an hour. So confidentiality issues with ICT, and also, and Dr. Amor, but it may have been the test case for a cyber attack. at Southwest Regional Health Authority, are the protection cyber issues robust enough, given the fact that the more digitized you become, it opens vulnerabilities from time to time with people, actors trying to create mischief and mayhem?
So before we go to Dr. Amor to talk about the specifics of Southwest, may I give through you, Chair, the ministry's position on protection of data. We are working with our lead ministry and our lead minister, which is Minister Bacchus, Ministry of Digital Transformation, to get the proper back structure to make sure, as far as humanly possible, our data is secure. So that is what I am doing at the ministry level. But of course, as you know, no system is 100% perfect, but we are taking more than reasonable steps with Minister Bacchus to protect our data. Dr. Amor.
Yes, with respect to the cyber recovery and now cyber resilience based on our incidents and plus working with the other arches and the ministry, essentially data redundancy, data security, having backup of data, and of course regularly testing our backups of data. All of that is in place essentially at this point in time. And as Minister said, working with other ministries and other expert assessment tools, we continually review that aspect of data security at this time. One other quick point to mention with respect to the digital trust, I gave the ED as the example, but this also extends as well to our primary care network, and in the context of NCDs, the primary care approach, where also doctors in primary care can also see images. Also, too, we are nearly complete to also generate the e-prescriptions in that environment. So within a smaller health center primary care setting, the patient care experience is very similar to what I described in the ED. You can go in, your information can be entered on the electronic record. We have access to lab results that are taken and assessed at the hospitals that come straight to the health center. Same thing for your imaging. And then when you leave the doctor consultation without a script, you can get it at the pharmacy at the health center. And we also have something at the Southwest called e-referrals. It means to say, if a doctor sees a condition and required to be referred to a hospital, you as a patient no longer have to take a referral and go to San Fernando to drop it off. We electronically generate the referral and we send it direct to San Fernando or the major hospitals and vice versa. And I say major hospital because that includes San Fernando and Point Fortin, so that patients are also experiencing this access to results, care, more real-time services, and more comfort for them, so that they could focus on taking care of themselves rather than trying to navigate the system on a paper-based environment.
Chair, before you proceed, you raise the issue that at town hall meetings, people say that they can't get their files.
But they say, not people, one or two people.
I just want to put on record that there is no policy to deny any patient and or his designated next of kin from getting their files. What happens, and I'm glad for this opportunity, is that persons who are either not the patient or not the designated next of kin request files. And we cannot give out confidential patient information to any third party. You will be surprised why unconnected third parties wish to see confidential patient information. So there is no policy to deny a patient, if alive, and or his designated next of kin from accessing files. I will say it again, very often, people who are unconnected for a variety of reasons want access to patient files. I will let Mr. Darwin Thomas come in here.
Oh, yes, ironic, though, that the very confidentiality posture that we have as an institution will prevent, for example, if you are a patient and a random member of your family comes and asks for your file, that we will vehemently say no on your behalf. You know, that is our policy. The designated next of kin will have to have, if you are conscious, your authority or your authorization to be able to access if you're conscious. Yeah.
Thank you. Member Singh.
Thank you, Mr. Chairman, and good morning again to Honorable Minister and your team. I have a couple questions. One in particular, I wanted to just shift back to the conversation about cancer. But having respect for time, we will sort of ask that question in writing. But just on the outset, Minister, you did say that in the past you would have taken initiative to ban sugar-sweetened drinks in schools. I just wanted to get from you the response in relation to that decision, having had the opportunity to explore that time that this was done. What were the results of that exercise? And if, because you mentioned we can't know if we can't measure, so were we able to measure the impact of that activity at schools? And in terms of the follow-up to that, the European Union prohibits or severely restricts many food additives that has been and have been linked to cancer. Some of these items, I mean, you know, Dr. Parasram might be in a position to identify some of these. So, Minister, if you want to just take that first part, and I'll move on to the other question.
Thank you. So the issue of lifestyle diseases in children, as I indicated before, it's a lifestyle change. It is difficult to measure the impact of any one intervention. So yes, we banned the sale of sugar beverages in school. But for a healthy child, the parent also has to make sure that when that child goes home from school, that they don't drink the beverage at school, at home. I have no control over that. The parent also has to make sure that when they go out for a treat, that treat isn't eaten every single day. So the chicken and fries is not an everyday thing. So what we have to measure is what is the overall impact of these changes. And again, the STEP survey may have some data on that, right? So I know we are looking for quick answers, but at the end of the day, this NCD epidemic, a large portion of the responsibility lies with the individual, parents especially, in how they expose their children to unhealthy eating habits. I will say it again. I never said not to eat doubles, not to eat chicken, not to drink soft drinks. What I'm saying, do it in moderation. Start to substitute. If you are drinking 3 soft drinks per day, drink 2 and 1 water. And then the following week, drink 1 and 2 waters. Kind of wean yourself off of the addictive nature of fast foods and sugar beverages. Dr. Clapperton?
Thank you. Yes, Dr. Parasram.
So, yeah, no, I mean, I think at the previous joint select we had on NCDs, we had alluded to a follow-up food consumption survey, which will take place. So we have begun the initial phases of planning of that food consumption survey, which is in collaboration with FAO as well, and World Food Program. Is that right? So we hope to roll out that in meaning the rollout being the actual data collection part of it. So it will give us a more in-depth look at what we actually consume as a public in a given day. So it actually is a very detailed tool that will measure what persons, very similar to the STEPS methodology, but we're aiming to do this by utilizing some sort of tele-survey where we can actually utilize phone devices to conduct the survey rather than the STEPS. In the STEPS case, we actually utilize CSO enumerators to go to the districts to collect physical data. So hopefully by the first quarter of 25 or thereabouts, we will begin our process of collection. Usually it takes about 2 to 3 months to complete that. So let us say by end of fiscal 25, we should have some preliminary data as to food consumption. But as Dr. Clapperton already said, in terms, there was a little component about consumption of fruits and vegetables in the STEP survey, which she already gave the data for, which suggests that we're not consuming the amount of fruits and vegetables as a population as we should be doing.
Thank you. Chairman, I just want to switch now to, based on the discussions at our town hall meetings, some systematic issues were raised, and I just want to touch on two, with your leave, as it relates to resource shortcomings among the RHAs. Some of our town hall meetings suggest that throughout Trinidad and Tobago, it was mentioned to us that staff shortages subsequently contributed to delayed appointment times for persons. I want to know, how is the ministry addressing these staff shortages of skills gaps that may affect the delivery of services at the various RHAs?
I will make an opening statement and then the two CEOs could come in. That is a very important question, Member Singh. It must be recognized we live in a world of scarce resources. The issue you have raised is real, but it is a global issue, especially specialized staff, especially staff trained in their particular specialties or what we call subspecialties. So, you have a cardiologist who is a specialist, but then you have pediatric cardiology, which is a subspecialty. There is a global shortage, especially of specialist healthcare workers. Having said that, we take every effort to recruit from abroad as far as humanly possible these resources, especially at the specialist level and the subspecialist level. But we are fighting with every single country in the world to get these specialists. I will now turn over to the two CEOs to say what they are doing operationally.
If I could you give us a sense of the particular specialist areas where you have shortages and what those would be, what specific disciplines those would be? Thank you.
Well, hold on.
So I think we could probably provide you that as a committee in writing, because we have been compiling a list of the ministry for many years, which we have used with our partners in other countries for recruitment purposes. So we can probably share that list in depth. But up to yesterday, I had a meeting with the Chief of Staff and the CEO at North Central related to staffing issues. And as Minister alluded to, the subspecialty characteristics tend to be the pervading talk of the day. So you have a internal medicine specialist, which we have. We have a DM program in UE that does that. But when you go to the subspecialty levels, like an endocrinologist, for example, you have difficulty with those. And it's cross-cutting across all the countries of CARICOM and the world, generally speaking. But we'll provide that in writing before you go over to CEOs.
So one solution before we go there, I mentioned that the ministry gave 8 scholarships for a DM program in oncology. So you target key areas, critical areas, and try to focus resources there. And as I said, those 8 persons have started training this month. So that is some of the policy decisions we make. So CEOs now.
We found consistent with what the minister and the CMO would have raised, that those subspecialties, as well as some of the highly technical categories of workers like the speech therapists and so on that support our behavioral services. So what we've done recently, quite recently, is we've recruited someone to actively engage overseas to find persons who are interested in providing services, some of those rare services at the North Central. We've had some success so far. We have a listing of some persons who are interested, neonatologists, transplant surgeons, etc. We've interviewed. We've recruited recently 2 speech therapists. Those were particularly difficult to find. And they are currently working at the Arima General Hospital at the newly formed behavioral unit. 2 pediatric behavioral psychologists. In particular, that was as well difficult to find, but we've recruited them through that assigned that person who we found on the market. So it's a work in progress, but in addition to the efforts that are being done by the ministry, we're engaging simultaneously.
Two-part question based on that response. And yes, I agree, specialists are in short supply around the world, and in some instances, other jurisdictions can offer more. So it's a challenge to get them to this jurisdiction. What are you doing to keep them? Because I have a friend who's highly qualified. She now works at Johns Hopkins, is Trinidadian, and said she was frustrated to leave the country because, well, she applied and didn't get any responses. And she was snapped up on the west coast of the US. Unfortunately, she's had to run from there because of the fires. And two, are there nursing shortages? And I don't know if this is an accurate data point or not, but the Nurses Association has consistently complained about nursing shortages, in particular neonatal nurses, which in their opinion, I don't know if this is accurate again, may or may not have contributed to the neonatal deaths we saw last year, unfortunately. Are there nursing shortages, and are there specialist nursing shortages in the country?
Well, in particular for us, we're always recruiting nurses. The specialist nurses, though, are of course more difficult to find, and so for example, we do have neonatal nurses within our establishment we do not have any vacancies as we speak of neonatal nurses. So we do have trained neonatal nurses. We do have nurses, whether it's in-house training or certified elsewhere. What we found, though, is that, and I think it's worth mentioning, is that the standards here in some instances are higher. So, for example, when we attempted to recruit some echo techs to bring them in to facilitate us, we were in situations where their training might be 3 weeks or 3 months, and our standard is 2 years. So that is always an issue for us, that we tend to have higher standards in terms of qualifications and training and duration of training. So once we sift through some of that, it's easy for us to facilitate. But we are currently engaging in the recruitment, particularly for the Arima General Hospital, to facilitate neonatal trained nurses, and we're looking for them throughout. But our establishments within the other hospitals are.
I'll go to Member Singh and then Member Ford.
Thank you, Mr. Chairman. And Mr. Chairman, I will just ask one more question and I'll wrap up my questioning. Minister, in the past we've heard about the notion about medical tourism. Is this something still on your radar, and or is it something that we have been exploring? And the second part to that question is, could you give us an indication or idea of a foreign national accessing medical services in Trinidad and Tobago, and walk us through an example, if one exists, where someone can walk into one of our public health facilities, be treated upon, and has to pay for the service via our health facilities?
Thank you. So the issue, let's take your second question first, because you have asked a really, really important question, the issue of foreign nationals accessing care. Let me say up front, if any of us here go to the United States or Canada and you fall ill, you have to pay for every single thing you get. Let's admit that. What we have done in Trinidad and Tobago, by cabinet decision of June 2018, I was asked by the cabinet to bring a policy position to treat with this vexing question. Because what you used to have were people coming here to be treated and taking up a bed where your family member should be lying on. The policy we have adopted is this. a foreign national, as opposed to other countries where you can't access any of this. You can access all public health services, for example, vaccines. You can access emergency care free of charge at any of our A&Es. You can access maternity care. That is the extent of which the asks the taxpayer to fund foreign nationals seeking care here. That is our policy, as opposed to other countries, where if you fall and you go to accident and emergency, you get a bill. You ask if we can charge? No, we have no capacity to accept money from anybody, whether it's a local or national. So I hope that, so like during COVID, anybody in Trinidad and Tobago, national or not, could get a COVID vaccine. Right now, I'm on a flu vaccination drive. Anybody can get a flu vaccination free of charge. Anybody can walk into an A&E and get emergency treatment. So you can get primary health care treatment to some extent, public health. So I hope that answers that, right? On the issue of medical tourism, that is not something the ministry is pursuing right now. What the ministry is focused on right now is further strengthening our local capacity. That is something, and you are quite right, that is something we should look at in the future once you have satisfied your local demand. So we will look at that sometime in the future. Thank you very much. Those are two really good questions.
I'm glad that was the answer. You'd have created,
You see?
You'd have created a maelstrom. Because you, just before I go to Member Ford, I remember CEO Thomas, when he came before us before, had given us some response times at his particular RHA, but our interventions and our interactions had provided different data points in terms of people going to the hospitals, and I'm going to give that some context in a bit, and having to stay 24 hours before getting attention. In some instances, having to sit in corridors or land floor in corridors, which I saw myself at Mount Hope, yes. And you had indicated, I could be wrong, that the general response time was about 8 to 10 hours. Could you give us a sense of what that is and how, and I know you made interventions that a lot of the time the public doesn't know. They clog up, I'm using the word loosely, they go to the hospitals when their ailments could be handled at the health centers. And you indicated that public information drive could have alleviated some of that load at the hospitals if people understood what they had to go to the hospitals for, which is basically critical care. So the question is, one, what are the response times to persons walking into the RHAs, the hospitals, for medical care? And two, how much progress has been made in terms of educating the public on what they should actually go to the hospitals for versus what can be remedied at the healthcare center and, if necessary, referred to the hospital for treatment?
Yeah, so we've taken the bull by the horns in 3 tiers. We've increased, because there's a finite number of patients who need to access emergency care. And those patients, and if we relate that directly with the NCD-related patients, are basically lifestyle patients. So on the one outer concentric circle, we're engaging in those activities that, like the wellness club and so on, to encourage lifestyle changes. And using the trans-theoretical transformation model, we're engaging to move persons from recognizing that there are activities that could happen. Usually there's a step called contemplation, and then there's a step called the step of engaging in the activity. We've engaged those free activities, for example, and we've started at Eddie Hart, where you get yoga, aerobics, etc., daily. No, so that's one tier because it's related.
Okay.
So that we will have, at the end of the day, less patients come into the system. At the primary care facility, we've bolstered our ability to engage those patients who need emergency care on the outskirts. So we've done quite a lot of refurbishment and systemic works at, say, Chaguanas District Health Facility. We've now opened at Chaguanas a premium emergency department that has inherent capacity to engage those patients. Prior to that, those patients would go to Eric Williams. So at Chaguanas, we have daily 100 or so patients that may have been would have been transferred, now staying at the outskirts. We're currently doing the same kind of refurbishment at the Arima District Health Facility, and that should be completed at the end of the month as per the mandate of the ministry. That will be completed, and so that we will have inherent capacity at that facility to engage in treatment of patients that would have been transferred. So if you look, so on the outskirts, we're attempting to stop patients from having the need of emergency care. At the peripheral facilities, we're engaging in enhancing the capacity at our district health facilities to deal with the emergency treatment of patients, and so that they could keep those patients. The net effect, and we're already feeling it, is the decrease in the numbers that are arriving at the Eric Williams Medical Sciences Complex, because those patients would have been transferred. We also have what we now term our overflow capacity of quote-unquote boarded patients. Boarded patients are those patients that would have been seen, and because remember, we have inherent capacity in an inherent number of beds within the emergency department itself. So we have an overflow that happens at Couva Medical Facility, but intrinsic to the department itself, what we've done is we've also hired EMTs. So as one phase. So what we've done is that those patients that engage the department are initially triaged by nurses, etc., and supported by emergency medical technicians who do routine checks on these patients. In addition, we've hired a cadre of what we call liaison house officers to facilitate boarded patients. And that is to say that if a patient is identified as a patient that is to be moved to a ward, and again, we have inherent infrastructure. We have 500 beds. And usually the numbers are way higher than that. So some patients inherently may have to stay in the emergency department. What we've done is we've bolstered our ability to care for those patients in the emergency department. So we've hired additional doctors whose only responsibility is to ensure that if you have, quote unquote, what we call a boarded patient in our department, that they ensure that they get the appropriate medications, that they get the appropriate direct visits, etc. That is being currently managed by a senior emergency physician, Dr. Paul, who basically ensures that that is happening. But simultaneously, we've recruited what we call a general manager, secondary and tertiary services. And what that person does is monitor on a daily basis the dashboards of the systems, and in particular, the relationships between the throughputs and or volumes of persons who engage the wards, so we're actively balancing the inputs into the department, the outputs to the wards, the discharges on the wards, and simultaneously, once we start seeing that it's bubbling into a place where the congestion will become difficult for the patient, we then start engaging other hospitals. So we transfer to Arima General Hospital, we transfer as well to Couva, we engage in ensuring that we have the right practices occurring on the wards to facilitate discharges. So it's multi-pronged and multi-tiered, and these are activities that I engage in on a daily basis.
Chairman, you raised a very important point, that you get this information at town hall meetings. I think it's an extremely important point you have raised, and between the CMO and I, we will let her expand on it. So when you have these town hall meetings, you are now chairing a meeting from a point of information, so you could judge what someone is saying. An accident and emergency department, what we have done and what I insisted we do, we expand our capacity to treat them. I understand the public's angst when you have your relative needing emergency care. But the layperson believes I must come into an A&E and within 5 minutes get a bed. That is not good medicine. Sometimes the best place to be for an acute condition is in an accident and emergency department. Because what we have done, we have increased and expanded the capacity for acute cases to be treated in an A&E, where you have a multidisciplinary team among you. You can get your CT as a priority, your X-ray as a priority. Once we put you on a ward, it means you are stable enough to be there, but very often the relative or the patient feels, I come to an A&E and within 5 minutes I go to a ward. That is not good medicine, because we practice in Trinidad and Tobago something called the CETA system in the A&E. And it is important in these town hall meetings that persons conducting these meetings understand how an A&E works. An A&E is not first come, first serve, which is what the relative expects. An A&E is worst come, first served, because you are trying to save lives. So we use something called the CETA system, which the CMO will go into. It's called the Canadian Triage Acuity System, which is geared towards treating the most acute, most serious person first, and make sure we save that person's life. CMO.
Thanks, very much. So the CETA system, in the simplest form, is ranked in 5 levels, level 1 to level 5, right? Level 1 requires usually resuscitation or something like the like, so you must be seen immediately. So if you're level 1, chances are you either come in by ambulance and you have to be seen immediately. Level 2, emergent, which is usually has to be seen within a period of 15 minutes. Level 3, which is considered urgent, must be seen in less than 30 minutes, and that is benchmarked internationally. Level 4, less urgent, which is less than 60 minutes in terms of time to be seen, and level 5, which I think is the category where you get most of the complaints, is basically non-urgent cases. Usually the wait time which is expected for that is less than 120 minutes. That's to be seen, and as Davlin indicated, the triage is to be left, and as a policy from the ministry. So the triage in the past may have been nurse alone-led. We have made the policy that has to be either nurse with doctor-assisted or full doctor doing the triage. So the doctor is the one that will do the assessment to determine what category you fall within, and then determine what treatment occurs after. What the ministry has done as well is we've put in a system of monitoring and evaluation that has standardized looking at the wait times across all the ANAs in the country, all 5 RHAs, and we have developed a tool together with the quality departments of all these RHAs. I think it was early on in 2024, late last year, where we are now measuring the wait times based on the CTAS scale to see basically how the performance of the varying ANAs match up to the international benchmark. So that is happening.
Can you give us a sense of the preliminary outcome of that?
So we should be, because it started late last year in terms of standardizing the tool, we have rolled that out to all the RHAs, and we should be getting preliminary data coming back to us in the first quarter of this year as to how they are performing. But I don't know if any of the CEOs want to say from their particular institutions how they have seen their CTAS, assessment performing. Brian, I don't know if you want to volunteer any of it.
In terms of CTAS assessment?
CTAS assessment and the level of performance with meeting the metrics that were set out by the ministry.
Yeah. Well, for the Southwest Regional Health Authority, you generally find the emergency and the urgent level 1, level 2. Those are like gunshot wounds, motor vehicle accidents. Those are seen immediately. Generally, patients, no relatives complain, and it is within the metrics. The level 4 and level 5, I'll leave out level 3 for last. Level 4 and level 5, those are patients who tend to walk in, self-referral, more ambulant, and more often than not, the reality is they will not be admitted because they don't require ward care. And as Minister said, whatever could still be sorted out in the emergency department can happen. You will tend to find complaints. Yes, we may have lengthened in some cases beyond the 2 hours. So like level 5, they said everything should be sorted in 2 hours. It may be a bit longer because what we find actually is on average 1 in 3 to 1 in 4 patients who come to the ED are in that level. And therefore, what we have done within the last 15 to 18 months, patterning from North Central, we have instituted now what we call a community liaison clinic. What we do is basically it's like a general practice clinic nestled within the emergency department. And we actually utilize our primary care doctors who are in the health centers to rotate into the system. So what you find happening is that if you come in ambulance self-referral, you're not going to be admitted. Your wait time, because of the other priorities, it may naturally lengthen. We actually, in the ED, send you to now what we call our community liaison clinic doctors. And apart from treating with you there and then, somewhat similar to the liaison house officer concept, but in an ambulance setting, we also indicate to you there and then, listen, there's a health center nearby. This is what the health center offers. We can do this for you in an outpatient primary care setting to help educate and intervene even in the emergency department busy scenario. The level 3 patients in the context of the NCD, those are patients who will eventually get admitted and they have complicated illnesses several times on account of chronic disease, a heart attack, evolving stroke, infections, and so forth. A lot of the cases are medical, and therefore, what happens to those patients as well? Generally, the KPIs are met, but in average, you will be charged in 10 to 15 minutes. To see the doctor may take you between 2 to 4 hours, and then we have to do tests and investigations that may take you another 2 to 4 hours. So we're talking 6 to 8 hours as a level 3 client. Complicated illnesses, we eventually going to admit you, but because you're coming so ill, we actually have to take that time to stabilize you before admitting to the ward. So therefore, overall, level 1, level 2 KPIs are met. Level 4, level 5 KPIs are largely met. It can be longer than average, but those patients are not going to die. Level 3 clients, we aim the KPIs are largely maintained, and based on everything that goes on in the ED, we know the level 3 clients are persons that need to be stabilized. And I would say overall, based on the KPIs the Ministry sent out, we largely meet those at this current time.
I just want to reiterate before we move on, because Dr. Moore said it. I understand the layman's angst. I understand it. But very often, the best place to be in your first few hours is in the A&E. That's where you get the most immediate treatment, and we stabilize you. If it takes a few hours to stabilize you, that is good medicine. But very often people expect, I come to A&E and I must go to a ward in 5 minutes. That is not good medicine. Our main concern is to stabilize that acute level 1 and level 2 patient, according to the CETA system. The levels 3 and 4, what we have done, as he said, within 2 A&Es now, like Nishogona's new A&E, we have level 1 and 2 on the ground floor and level 3 and 4 upstairs. So that is a model, level 4 and 5, sorry, upstairs. So that is a model we are starting to use. So just to recap, very often, the best place for the acute patient to be is in the A&E, where they have everything around you, all the consultants stabilize you, and then we send you to a ward.
I'm just going to exercise more effective time management
Sure.
now, because we're aiming for 12:30 end. I'm going to go to Member Sinanan, Member Mohit, and then Member Ford, as we seek to make that deadline.
All right, and I will be short with my question. But basically, what I've heard from the team at the Ministry of Health is, I mean, clearly you all have a plan. You all are working towards it. We understand the healthcare system. You will always have challenges because what we operate in Trinidad basically is a free public health system. And there will always be challenges, but we can see that you all are at least getting to what is called basically the international benchmark standard. That's what you're gearing for. And you will always have people who may not be satisfied, fully satisfied. So you will always have complaints. Complaints you can't really ignore because you have to strive for a first-class treatment, even though it is considered a free public health system. How do you track and monitor complaints?
So I have always told people, coming from a marketing background, that complaints are a gift from God. It is only complaints that drive you to improve. So let me say that up front. We welcome complaints, especially genuine complaints, genuine ones. So at the Ministry of Health, on becoming minister, I started to track complaints. I will give you the global picture, and then the CEOs can go into the microcosm that exists in their RHAs. In 2015, this, as you said, Member Sinanan, this free healthcare system, we were doing 1.5 million patient interactions. Now, people confuse that figure. They say, well, we only have 1.3 million people in Trinidad. Patient interaction, because one patient may interact with the system 20 times for the year. We were doing 1.5 million patient interactions. The number of complaints we had was 6,612 out of 1.5 million patient interactions. The resolution rate was 74%. We were able to resolve 74% of that. But the way the question was phrased from Minister Sinanan, what was the client's response? The client customer satisfaction rate in 2015, doing 1.5 million patient interactions with 6,612 complaints, the satisfaction rate was 53%. Only 53% of them was satisfied with the way the complaint was dealt with. By 2024, we moved from 1.5 million patient interactions to 2.2 million. We measured it. This system was being interacted by our population 2.2 million times. But look at what went down. The number of complaints went down from 6,612 to 2,095. And the satisfaction rate went up from 53% to 75%. So it means we take complaints seriously. It is a gift because that drives us to improve. That is how I measure it at the Ministry of Health. So the CEOs could tell you now what they do on the ground with complaints and how we treat with them.
Through you, Chairman. Thank you, Minister.
Loath to do this, but I'm going to beg you to be as concise as you can
Sure.
in the interest of time.
Sure. I would say in summary that at the RHAs we work with our quality departments where there's a telephone hotline, in our case is 87 SWARA, and persons can come into either the offices or call through the line and make complaints. All complaints are taken seriously. I'd like to emphasize that point, and several complaints are very good suggestions for process improvements. So therefore, we try to speak to complainants if they come in person, or if they call on the phone, or if they write the ministry of the RHA, we contact them within 24 hours and we investigate. And we actually, while we resolve the customer complaint, we also still look on the back end for the process improvements, if it's an issue with staff or services. Our overall satisfaction rate is similar to the national average. It's currently at 75%.
Similarly, at the NTRHA, the issue is that we report directly to the board regarding complaints via the quality committee. We also have what we call a service improvement committee, so that whilst we collect and analyze and synthesize the complaints that come in, we engage in the activities that would create experiences that exceed the expectations of the clientele. So for example, we now have liaisons and ambassadors at the front of the building. When you come in for an appointment, particularly first appointments, there are people there expecting you, directing you where to go. That's just one of the innovations, but that came out of the Service Improvement Committee.
Thank you. Member Mohit, quickly, then Member
Chairman, thank
Monroe,
you very much. Mr. Chairman, it has to do with the hours of health centers. But firstly, I just want to say that I would like to publicly commend the attendees of our town hall meetings. I have just listened to the minister where he would have indicated that the worst are treated first. But in some instances, what we have heard at those town hall meetings was that of patients would have experienced the long waiting periods of 10 to 15 hours, sometimes running into 24 hours. So whilst I commend these attendees, it was our job to listen at these town hall meetings. And, those attendees, what they would have said at those town hall meetings would have triggered a lot of approaches, of which I am learning of today. We would have met with the RHAs, etc., during the last year, and what we are hearing today, I would say that these were triggered based on the voices of those people who would have attended those meetings. With that being said, Minister, I know you mentioned, and the CEOs of the RHAs, that you are trying to lessen the loads at the Eric Williams, etc., by having the primary health facilities be utilized more. With that being said, there are some primary healthcare centers which are opened for limited hours of the day. Do you have any plans to have some of those facilities at least opened for a 24-hour period?
Okay, so we need, first of all, I did say complaints are a gift from God. So coming out of those town hall meetings, we pay attention to those complaints. The issue of opening of primary health centers, we have to understand there are different levels of health centers, right? And the CMO will explain why some health centers, based on their designation, are open for certain hours. So
basically you have categories of health centers. So the categories would begin with something that we call an outreach health center, which is basically usually open 2 or 3 days a week. In the past, we would have had some of those in far-flung areas where you have a service 2 or 3 days a week. One of them in the past would have been Las Lomas. I think that was changed in the recent past. Beyond that category, so you go from outreach to the regular health centers, which are open Monday to Friday, 8 to 4. That's the regular health centers that persons are accustomed to. It usually provides services for chronic disease, generally antenatal care, immunization, and a lot. That's the common health center that people are aware of. There's the Enhanced Health Center,
Correct.
which is what Davlin and Brian alluded to, the CEOs. And those are usually put in close proximity to an accident and emergency department, where they also have a general practice clinic that can see CTAS 4 and 5 levels. So they take some load off the A&Es. And in general, they either open the health center part, so there's a health center component plus a GP clinic. Health center component goes from 8 to 4. The GP clinic goes from 8 usually to 10 or to 12 at night. And the district health facilities are the last component of the health centers, and those usually contain a health center as well. But they also have an adjunct accident and emergency. For example, Shagona's health facility, there's a district health facility, as well as Kuva, and those go, the health center part again, 8 to 4, and the A&E part goes 24 hours from Sunday to Sunday. So those are the different categories. In terms of looking at the landscape and utilization reports, from those centers, we determine if, for example, our outreach center needs to open 2 days a week or they need to open 3 days a week. So based on utilization reports, based on proximity of one health center to the next, for example, if you use the Las Lomas example, you would find that there's a larger health center, Cunupia, which is not too far flung from there, and there's St. Helena, again, geographically very close. So hence the reason it may not have to open all 5 days of the week. But we use that type of data to determine the hours of opening as well as the days of the week that the center should be open.
Thank you. Member Monroe, and then Member Ford.
Thank you very much, Chairman. Minister, I know we have a time constraint, but quickly I just want to find out two things. What are the reasons for our decline in fertility rate? 1, and 2. Now, our fight against NCDs. Strategic partnership and collaboration with the private sector and civil society is very important. I want to know, and the committee would like to know as well, what are the additional support needed to support community organization and NGOs to drive grassroots health promotion initiatives? Member
Monroe, you want to get me in trouble today. Declining fertility rates, yes. I'm beginning to regret I said that on Christmas Day, but it is a fact. Okay, briefly, for a population to renew itself over the course of a woman who is fertile, 15 to 49, I believe, you need to have 2.1 children per person to renew their population. We have been declining over the years. What are the reasons? In the absence of a study in Trinidad and Tobago, I will tell you what the global trends are, and we could extrapolate or assume. One of the reasons families had large amounts of children in the old days was because of infant mortality. Many children died before the age of 5. So you were having a lot of children because children were dying. With the advent of immunization, children live. So there is no need for those families to have replacement children. As societies move from underdeveloped, developing, agricultural to industrialized, you don't need many children to work a farm in the old days. That's one of the reasons families globally in the old days had children, cane cutters and so on. With the advent of modern contraception in the 1960s, especially birth control pill, mean that women had more control over their reproductive cycle. And then globally you notice as countries become more industrialized, more developed, as more and more women take their rightful place in tertiary education and the workplace, fertility rates tend to decline. That is a global picture. But in the absence of any study in Trinidad and Tobago, I am just putting that global picture there. So I hope that gets me out of trouble.
Well, replacement children may get you in more trouble.
Yes, I know, yeah. But that is a fact. When you read the literature, that is a fact. When your children die at age 2 and 3 because of polio, measles, mumps, scarlet fever, but now you have vaccines and children live, right? So that's a fact. On the issue of NCDs, yes, we work closely with many NGOs, On the diabetes front, we work very closely with the Diabetes Association, and they actually get a grant from us. We work with the Cancer Society of Trinidad and Tobago. They get a grant from us. We work with this cervical cancer group, Ayana Diet Foundation. We work with them. And any of the NGOs that we can work with to spread the message and spread the burden, yes, we are free and willing to work with them. So, Member Monroe, I hope that answers your two questions, briefly.
Let's go to Member Ford, and I'll come back to you. Member Ford, go ahead, please.
Sure. The timing of my particular question at this time, Mr. Chairman, but I'll still throw it out, and the minister could, give us a brief comment, or if he desired to send it to the Secretariat in writing. As we know, strategic partnerships and collaborations with the private sector and civil society are paramount. And you just mentioned, one or two NGOs in your last discussion. What is the current collaborative relationship between the ministry and civil society groups, such as the Cancer Society, Diabetic Association, Heart Foundation, the Pharmaceutical Board? Honorable Minister, how does the ministry plan to strengthen these collaborative bonds? Has there been any challenges with providing resources to help civil society groups, NGOs, to achieve their mandate?
Okay, thank you.
I don't know how brief you can.
Yeah, so I just spoke about the Diabetes Association. I spoke about the Cancer Society. They get grants, they get resources from us. We work with them. Ayana Diet Foundation on cervical cancer, we work with them. So we work with the Autistic Society of Trinidad and Tobago. We work with Animals Helping Humans for Autism. There are 18 NGOs that we currently provide subventions for. We provide subventions also for drug addiction, those people dealing with drug addiction. So there are 18 NGOs. You mentioned the Pharmaceutical Society. They are not an NGO in the true sense of the word that receives a subvention. They are a professional development body for pharmacists, but we do work with them. Whenever we need advice and so on, we call on them, and we have a very collaborative relationship.
No major challenges as such?
No.
Mohit?
Thank you, Mr. Chairman. Quickly, Minister, seeing that we have you here and we are dealing with health facilities and management, and we heard so much today about Shogunas district facility. One of the burning issues in the district of Shogunas, and one of the questions raised at the town hall meetings, was that of a health facility, a proper new health facility to be constructed in the district of Shogunas. Do you have any information for us in terms of location and when that will be constructed, given the traffic horrors in Shogunas as well?
Member Mohit, like Minister Sananan, you seem to be in the Ministry of Health. So, excellent question, because you are right. Shogunas is one of those burgeoning areas. There was an ad in the paper about 3 weeks ago for proposals to build a new Shogunas health facility. So that is on the cards, and we hope, I think UDICOT put out the request, and I will have to check with UDICOT to see how far we have reached.
If we could end where we started, Minister, before I give you a chance to bring closing comments. We started by focusing on the importance of preventative initiatives, and Dr. Clapperton gave us some interesting data points on the survey. I know the ministry has invested a lot of time and effort in the TT Moves and TT Moves Junior programs. Can you give us a sense of how you're tracking the success of these programs? Thank you.
Thank you again, Chair. So all of the programs and initiatives that have been implemented in their design stages or planning stages have a monitoring and evaluation component built in. So when they have rolled out, at those stages, we may be collecting data, or after completion of some of them, we would be reviewing, sometimes based on participant feedback and the amount of persons participating as well. So we have been collecting data on several of the programs that have been implemented.
And just quickly, when the minister spoke earlier on about changing the trends, when Dr. Clapperton gave the data on alcohol consumption and food consumption, we are going into we are in the carnival period. We're not going into, we are in the carnival period. We have this feature called All Inclusives, which promote free drinks, free alcoholic beverages and other beverages, free food. And culturally, it's one of those paradigms that shifts Trinidad and Tobago into high gear consumption for a 3-month period. Well, actually, no, it's for a 4-month period coming out of Christmas into Carnival. How does the ministry deal with that cultural aspect of trying to change the trend? Because that's a whole quarter of a year which can impact the data for the whole year, if you look at it.
Yes, thanks. Chairman, that's a very good question to ask. Overindulgence in alcohol at any time of the year is not wise. But we do tend to overdo it in the carnival season. And every year, through the Ministry of Health and its daughter agency, NADA, we do put out public advisories as to how the population should conduct themselves into what they eat and drink and consume during Carnival. So NADAP always does this, and 2025 is going to be no different. But coming out of Dr. Clapperton's research with the STEP survey, we do seem to have a shifting demographic in alcohol consumption, especially amongst females, which did not show up in the 2011 survey. And this is the benefit of doing these surveys every 10 years. So I want to make an appeal through you to not only women, but to all persons that, like everything else, moderation is the key. And you are quite right, this 3-month period, we are going to have excessive use of alcohol, but NADAP is on the ball. Thank you.
We're also exercising a bit more, even if it's for only aesthetic reasons.
Yeah.
Minister, in closing, would you like to present some closing comments, please?
Yes, thank you, Chair. Well, first of all, I want to really thank you, Chair, and members of the committee for your excellent questions. I think the public is much more informed as to what we are doing at the Ministry of Health and the RHAs. I want to take the opportunity to thank all 22,000 healthcare workers who do their jobs diligently every single day, 24 hours a day, 7 days of the week, Christmas, New Year's, Eid, Diwali, doesn't matter. It's a professional cadre that we and I am proud to lead. And I want to thank you once again for the opportunity, and I think we have educated the public through your kind intervention, Chairman. Thank you.
Thank you so much. We'd like to thank you, Honorable Minister Terence Dialsing, for taking time to be with us, particularly under the circumstances where we know we're not well recently. We really appreciate you making the extra and coming out. Dr. Parasram, ORTT, Chief Medical Officer, Dr. Brian Armour, Chief Executive Officer, SWRHA, Mr. Davlin Thomas, CEO of the NCRHA, and Dr. Maria Clapperton, Director of the Non-Communicable Diseases Unit. We'd also like to take time to thank members of the online audience. We were streaming live on YouTube for their questions and comments and insights, and invite the ministry to send any additional information that you think the committee can use in its final report on this inquiry. We'd like to thank also members of the committee and, as usual, the Parliament Secretariat for the unstinting support in this endeavor. On behalf of the committee, I'd like to thank you all for viewing, and this meeting is hereby adjourned. Thank you so much.